I'm going to let Deborah Issokson and Lisa Waxman introduce themselves. They've come to talk with us tonight about postpartum depression. I want to explain to welcome to the conference call. I want to explain to Deborah and Lisa that we're a mixed group here. Some folks are volunteers on the parental stress line, which is a 24-hour stress hotline, where we receive quite a few calls from mothers either openly saying they have postpartum depression or the counselor thinking in their mind the person might be exhibiting signs of postpartum depression. And we all would really like to learn more about it. And we have facilitators of support groups who have women with postpartum depression who attend the support groups. And we have some other interested folks in the community who decided to come. So I'm going to just go around the table quickly and have everyone say their name and what brought them here tonight. And if you have any specific question or thing about postpartum depression that you're interested in hearing tonight, just throw it in. I'm Amy Bryn. I'm the program supervisor here at Parents Helping Parents.
I'm Andy, and I'm a volunteer on the stress line.
I'm Bobby. I'm a volunteer on the stress line, and I also have a question about one of my callers who had a miscarriage and was extremely depressed. Or she is. And I didn't know where to call.
I'm Carol. I'm also a volunteer on the stress line. Just last week I got a call regarding postpartum and kind of didn't have some referrals.
I'm Aura. I am not yet, but will eventually, I think, be helping lead a group maybe at Rosie's place.
Oh, great.
Oh, great.
Welcome.
And, I'm interested in diagnosis versus self-diagnosis.
Okay, great.
I'm Michelle. I'm Outreach and Development Coordinator for Parents Helping Parents.
I'm Jeanette. I'm from the community.
I'm Wendy. I facilitate a group at a shelter in North.
Great. Is there anybody on the conference call who'd like to introduce themselves?
Sure. This is Randy Block. I'm the director of PHP, and I facilitate the Chelsea group at the moment and cover shifts from time to time when necessary.
Great, welcome. Anybody else on the conference call line? Okay.
Yeah, we've got one more person here.
Oh, I'm sorry.
Oh, I'm Ruth Ehrlich. I'm one of the volunteers on the stress line.
Okay, so I'm Debbie Issokson. Or is a blast from my Brandeis past.
I thought I recognized the name when I heard it.
I'm a psychologist in private practice in Wellesley and in Pembroke. I have a general psychotherapy practice, but my specialty area is reproductive mental health issues, perinatal mental health. So I'm seeing women everywhere from preconception all the way through postpartum, sometimes through multiple children over time. And one of the things I do is a lot of training and teaching around this issue, and some writing for Our Bodies Ourselves, and a couple of articles here and there. So, Lisa, why don't you introduce yourself, and then we'll jump in.
My name is Lisa Waxman, and first and foremost, I'm a survivor of postpartum, what I thought was depression, but was actually anxiety. 3 years ago, from January 2007, when I had my son. I'm doing very well now, and I'm also a licensed independent clinical social worker, but my background's in geriatrics, but I've found a new career, and I am primarily an advocate. I am a volunteer for Postpartum Support International, an organization that you'll find on your handouts, and we'll probably talk a little bit about tonight, which is a leading international organization with regard to perinatal mood disorders. Puts out great information, leads the way in advocacy, legislation, clinical issues, everything. And I am a volunteer for our Massachusetts Warm Line, which we'll talk a little bit about more later, which will be very important for you all to know about. I'm also on the North Shore Postpartum Depression Task Force up in Essex County, where we're gathering information and resources and kind of getting to the root of what the prevalence is like in our community and developing resources of treatment and support in that area. And that's about it. So what I'm hoping to do tonight is give a little bit of clinical material, enough for what you're all doing. And if you want more, please ask. And I want to be able to talk about, sort of the facts of postpartum mood disorders. And, I'm saying postpartum, but in fact, we know that lots and lots of these women have prenatal mood disorders. So we like to use the word perinatal, but we often say postpartum depression because that's the phrase that everybody finally knows. The good news is there's more public discourse. The bad news is that it's not exactly accurate. But you'll hear a lot of women say, I think I have postpartum. You can't have postpartum. Postpartum is the period after the baby comes. But it is in the vernacular now. People say, I have postpartum, and that's sort of our jumping off point for lots of us. So I'm going to use all the words interchangeably, but I like to think of it as perinatal. And someday maybe you'll be getting calls from women while they're pregnant. And I really love working with women during pregnancy because then we get to do some preventive work so that even if the pregnancy is a little rough, the postpartum time, once the baby's here, is easier. So I'm hoping to talk about some facts, some clinical material, causes, treatment, prevention, and most importantly, what can you all do in your particular roles? As a therapist, I get 50 minutes with somebody multiple times. You often get however much time you're allotted on the phone with folks or in your groups. So I want to make sure that whatever information I impart tonight feels completely relevant to your particular role. And so ask away whatever questions come up. And I welcome questions based on the phone calls you're getting and the families that are in your group. And Lisa's going to tell a little bit of her story. But what I want to start with first is a little piece from a novel. And it's called The Vision of Emma Blau by Ursula Heggie. Lots of people never read her book, but they did read Stones from the River. This book came after Stones from the River, but tells the story of what happens before Stones from the River. I don't know why authors do that. But anyway, in this book, if you remember, for those of you who read Stones from the River, there's a dwarf in the story. Do people remember that?
A little bit,
Okay.
yeah.
Well, this is the story about when the dwarf is born. And this little piece is about what happens to the mother when this baby is born, and more importantly, what happens community-wise, and really speaks to the shame and secrecy surrounding postpartum issues. And I'll talk a little bit more about that, my comments on it after, but I just want to start first. So the woman's name is Gertrude, and she gives birth to a little girl who's a dwarf. And she starts to act really crazy, according to the other people in her community. And she won't touch the baby. She runs away when the baby cries. She blocks her ears. As I was reading it, I was certainly questioning her prior mental health, but we don't get to find out about that in the story. Other women were scornful of Gertrude, and though they kept her fed and cared for the baby, they would never accept Gertrude back as being one of them, because she had broken the natural law of being a mother. She had challenged other mothers by magnifying that moment every one of them had felt, a moment when you are so depleted by a child's needs that you can't bear to go near it, a moment you forget instantly because it would shame you to remember, and you will never understand that other mothers have felt it too, because none of you will speak about it. As much as there's more public discourse about perinatal issues, it's made it into soap operas, it's made it onto nighttime dramas, there is still an enormous amount of shame and secrecy. Women often will go to new moms groups and never talk about how they're really feeling. They will not tell people in their families, they will not tell partners. They get dressed nicely, they put on a happy face, and they're completely miserable. And there's less stigma attached to going to counseling, and yet there is still a ton of stigma attached to it. And there's this huge cultural myth, of course, that this is, if you're a woman, this is supposed to be the most wonderful time in your life, and it's not for lots of people, for all kinds of reasons. And so we're going to talk about what some of those reasons are.
Let me just start with a little statistic, which is that 10 to 20% of new mothers will have some kind of perinatal mood disorder, and that's going to include depression, anxiety disorder, obsessive compulsive disorder, and on rare occasions, psychosis. Now, one of the reasons there's a lot of confusion, mystery, even lots of mental health folks who don't know much about this is because they'll say that in the general population, the percentage of women who can expect to be clinically depressed following birth isn't really any greater than for the non-childbearing woman. And in fact, in our diagnostic manual, there is no separate diagnostic code for a perinatal mood disorder. If I want to give a proper diagnosis for insurance purposes, I would have to put major depression, which nobody wants in their health insurance record if they can help, and then if I were to write a narrative, I could write a narrative that says postpartum onset, but there's no code that says that. So there's no official diagnosis. There are lots of people who believe this isn't a real thing. And if the medical world, the mental health world isn't validating this and talking about it accurately and properly, then of course the public is going to have a hard time discerning what's going on. And someone asked before, self-diagnosis versus official diagnosis. There's a lot of fuzziness about this, and I will share a little bit about how I see that, but I want Lisa to tell a little bit of her story first so we can kind of hear the experience of it all, and then I'll get back to some clinical information.
And it's a great segue with the self-diagnosis versus actual diagnosis, because I had a mental health background. I am a clinical social worker. I had a history of depression. I had a diagnosis of what's called dysthymia. Some of you may have heard of that. It's a low-grade type of persistent depression that is less episodic as major depression. And I was on medication, and I was on medication for years. And I was just kind of in autopilot, feeling fine, and I got married, and my husband and I wanted to have a baby right away, and I thought, well, I'd like to have a pregnancy without medication. So I went off my medication, and I got pregnant right away, and I thought my pregnancy was fine. That I gave birth. The birth was very uneventful, thank goodness. I mean, uneventful medically. The baby came quickly, within 15 hours. He was perfect, beautiful, but I just immediately stopped sleeping. I came home from the hospital on a Sunday, and couldn't breastfeed. My baby didn't latch on. And Monday I went out to go get some bottles, which I had not expected to do, and I was a nervous wreck. I didn't know anything about bottle feeding. I had taken breastfeeding courses. I was expecting to breastfeed. So I went and bought the bottles. I came home and I sterilized them. They were boiling for an hour, and then 2 hours went by, and then 3 hours went by, and then I took them out of the boiling water, and I rinsed them off, and I boiled them again. And I spent the whole first day boiling bottles because they weren't sterilized enough. I didn't sleep that night. I didn't sleep for the next 19 nights. I was a wreck. I thought this is how new mothers felt. After a couple of days, though, I started to think maybe there's something physically wrong with me, because I felt this adrenaline rush. This is the best way to explain it. This adrenaline rush going through my body as if I was speaking in front of 3,000 people. And I couldn't sit still. My heart was racing. I had a very dry mouth. And I was talking very fast, and I couldn't relax. And the worst part of it all is I couldn't hold the baby without crying. And I really thought that there was something physically wrong with me, so I started calling my obstetrician, and I said, there's got to be something physically wrong with me. It's got to be my hormones, my estrogen, my something. Please, let me come in, take my blood, tell me what it is, and give me a pill. And she said, no, you'll be fine, just give it a couple of days. So a couple of days went by, I still wasn't sleeping, I was still pacing around, I was up all night, I was still crying, and I kept calling her, and she eventually stopped returning my phone calls. Her nurse would return my phone calls, and it was basically a blow-off, like, you'll be fine, just relax, blah, blah, blah. And I said, please give me something to relax. I'm not breastfeeding. I need a sleeping pill. And the doctor called me back, and she said, I can't give you a sleeping pill because you're a new mother and you need to be alert for your baby. This was in 2007. This was in Winchester. This was in what I thought was the healthcare mecca of the world, and this was the response I was getting. So a couple of days went on, and I was still a panic wreck, and I actually called the obstetrician on call during the weekend between deliveries. And I would have called the parental stress hotline, but I didn't know the number. So I called the obstetrician on call, and I asked her to please help me. And she said to me, do you drink herbal tea? And I thought, is she kidding? But she was very nice. She gave me 3 pills of I think, Ativan or Xanax or something. This went on, and I just kept calling. I called an old psychotherapist of mine who could see me a couple of days later. Very, very long story. I was hitting dead ends left and right. So 3 weeks later, I insisted my husband come home from work on a Friday morning, and he said, well, what am I going to do? And I said, I need you to come home and take care of the baby. And he said, well, where are you going? And I said, I'm going to the emergency room. And my husband said, what are they going to do for you? You're fine. There's nothing wrong with you. And I said, I have to sleep. And he said, okay, we'll go to the hospital, but they're going to send you home. He didn't understand what was wrong with me either. So I went to Winchester Hospital. It was the middle of flu season. It was beginning of February. And the first light of hope met me. That was the triage nurse. She recognized what I was going through. I was a wreck. I hadn't slept. I was crying. I was full of anxiety. And she said to me, you are going through a postpartum crisis. And I don't want you to sit in the waiting room with all of those people with the flu and all their other issues. Come and sit here with me. I don't know what we can do for you, but we'll do something. And I sat there with so much shame 3 weeks after I had my baby, 3 weeks today. So much shame going through me thinking, I can't believe that I wanted this baby so much, and I'm not even able to take care of him. And I'm here in an emergency room asking for help, and I don't even know what kind of help there is for me. But all I want to do is go to sleep. So what they did is they sent me to McLean Hospital, and driving through this area is always so wonderful for me. And I slept. They got me on some medication, and I started back on an antidepressant, an old antidepressant that I was on, and I was discharged a couple of days later with a very bad discharge plan. It was kind of like, okay, here's your pills, 30-day supply, go find your help. And again, I was thinking, I can't believe this. I'm in the healthcare mecca of the world. I just came out of this supposedly great psychiatric hospital. Nothing against McLean Hospital, but it just wasn't the best discharge plan for me. So I was feeling a little better, and I put some of my social work skills to use, and I found Postpartum Support International. And I found the Massachusetts Warm Line, and I have the number written down there for you all. And I left a message, and a wonderful volunteer called me back. She happens to be a clinical nurse specialist, psychiatric nurse practitioner, who was about 5 minutes from my house in private practice. And she saw me right away and got me on the road to recovery. So my story is much more involved than that, and I guess I kind of point that out because I thought I had postpartum depression, self-diagnosis, mental health background. But when I look back on it, and after working with my therapist, I was suffering from anxiety. I was having panic attacks. I couldn't sleep. I don't know what the DSM would be. Would it be, generalized anxiety disorder, postpartum onset? I don't know, but that was my main thing. And I've learned so much since then about my postpartum anxiety disorder. And then, indeed, I look back on my pregnancy, and I had a lot of obsessive, compulsive thoughts. when the men came to deliver my crib for the baby, the first thing I asked them was, what's your return policy? Because I didn't think I was going to bring home a baby who would be alive. I upset during my pregnancy that my baby was going to be born and not make it home from the hospital. So, you know, throughout our discussion tonight, I may add in a little bit of my personal experience. Steph, go ahead.
Thank you. Lisa's story highlights so many things that enrage me. Not the least of which is no new mom should be ending up in the emergency room. We know enough. We know, the information is out there about how to screen people prenatally, how to make a postpartum plan for people who have red flags and risk factors, that if everybody is doing their job correctly, except for psychosis, we shouldn't be having women with new babies in ERs. It just should not happen. It is the most horrible place to go. And in spite of how fabulous our hospitals are here, they don't know what to do with postpartum women. They don't know what to do with breastfeeding women and medication. That totally freaks them out. If you're unfortunate enough to struggle with a postpartum disorder and need to go to an ER in July when you've got the new residents in all the hospitals here, well, really forget it. And so it just enrages me. I will share one other little story that fuels my rage, which is that I got a call one day several years ago from a woman who said, my daughter just had a baby and she's in the ER, and can you help us? Well, what I learned was that this young woman had a pretty extensive mental health history, an eating disorder history. She was seeing a group of practitioners who I knew to be fairly savvy, and nobody pegged her as being at risk, and nobody thought to hook her up to a therapist during her pregnancy. And now she's in the ER, and they don't know what to do with her. And I just, makes me so angry. We don't live in East Podunk. We live in Massachusetts. This is the Boston area. They do tons of this research at Mass General. The information is at the fingertips of any medical professional who wants it. But either they don't know how to access it, they don't really know it's there, or they don't want to take the time. And we're talking about fragile times in people's lives, you know, and it just makes me so angry. But this is what is out there at the moment, and though it's better, it's a little better than it was 2 years ago, it's 3 years ago, it's still actually not great. And so the more we can all learn and in our respective roles do our little piece and pass information along at cocktail parties, the better. So there are a million pieces of information here to tackle, and I'm just going to throw a lot at you. If you don't want to take any notes, that's fine. Lisa put some websites on your sheet. The Postpartum Support International website is a great website that has all this information I'm going to give you. It's got symptom lists, it's got treatment options, it's got information about medication. The Mass General website, is that? Okay. What else did you put on here? That one's not on here. I'm going to give you two other websites actually we didn't put on here. I'm going to give those to you now because these are two other good resources for some basic information, if you remember nothing that I say to you tonight. So the first one is womensmentalhealth.org, women's with an E, womensmentalhealth.org. That is the website for Mass General's perinatal psychiatric program. And when you go on their website, there's a part about pregnancy, a part about postpartum, there's a part about menopause, there's stuff on breastfeeding, and it's really good, easy to read, easy to access information about the different clinical diagnoses, and there's a whole lot of good stuff on there about medication and the latest and greatest from the studies. So if a woman is trying to figure out, is it safe to take it, is it not, she can go right there to that site and at least get a blurb. So, and she can tell her physician or her midwife or whoever, please go to this site. So that's a great site, and it's our wonderful local resource. We're very lucky to have it. And while I'm talking about Mass General, I'll just say that it is a place you can refer women for medication evaluation. They do not provide therapy there, and they do not even prefer to provide ongoing medication management. But it is a place where women can go and get an evaluation. They write a decent report. They will send it to the local therapist, the OB, the local psychiatrist. They'll make their recommendation, and within the letter, they also explain what the research says about these medications and breastfeeding, or these medications during pregnancy. So a woman will walk away with some really good information from that session, but then they like to tell you to go connect yourself to a local person. Depending on when someone calls, it can be a long wait to get in there, but sometimes you just hit it at the right time and they can get you in. They have several good people. So that's a great place to send women, especially women who have more complicated histories. Another website where you can get really good information, and so can lay people and the public, is mededppd.org. It's mededppd.org. And on that site, there's a little, you can click if you're a professional, or click if you're, I don't know what word they use if you're not a professional, but it is filled with the latest and greatest information, research, journal articles, lots of links to blogs and chat rooms and other websites, and it's an amazing resource, partly funded by the government, and it's really good. And lots of people who are big in the perinatal mental health field have consulted and contributed to that website, so it's a really solid one for people to go to. So let me go through sort of symptoms and categories. Now, remember, these are not categories according to the Mental Health Diagnostic Manual. These are categories according to the mental health folks who do this perinatal work. Whether or not this ever gets in our DSM, I don't know. We finally got premenstrual dysphoric disorder in there, so maybe in another century we'll get perinatal mood disorders, I don't know. For me, what matters first and foremost is what is the woman experiencing. For insurance purposes, I need to come up with a diagnosis. For medication purposes, we need to be fairly accurate at what we think we're seeing, because you treat depression differently than you would treat bipolar disorder, and you need to know about that stuff. But for me, I don't care if a woman meets every clinical criteria of this diagnosis. What matters to me is how is she experiencing herself and her time with this baby. Is she able to care for herself and her baby and stay safe? How can we help her feel good about herself? Is she sleeping? Is she eating? So I will say to people, let's not worry about diagnosis first. Tell me what you're experiencing. I think it's important to use the phrases postpartum depression, postpartum anxiety disorder, postpartum OCD, or prenatal da-da-da-da-da, because it reminds us of the context, that being that there's a baby in the picture. As I say to clients, if you're someone who's had a history of depression previously, and you were feeling miserable, you could stay home, keep the shades down, not eat, stay under the covers, not go to work. You're just hurting yourself, but there's nobody else at risk. If you have a baby and children in the picture, you can't just check out. They need you to get up and out of bed and pull the shades up and make sure there's food in the house. And so context is really important here. In that way, because there's a baby in the picture, these, and I hate this word, but I'm just going to use it, disorders, these disorders take on a whole other meaning. For instance, the symptoms of postpartum depression, in large measure, are the same as any clinical depression: tearfulness, irritability, inconsolable sadness, feeling oversensitive, sleep disturbance, appetite disturbance, fears, anxieties mixed in, sometimes suicidal ideation. That's all the clinical criteria for any depression. But then there's the baby. So we have excessive worry about the baby's health, worry that you're not being a good enough mother, fears about the baby. You know, there's all this stuff that weaves in the baby and self as parent. And that makes this look different. Now, I will say that postpartum depression and perinatal depression is different than the blues. The biggest difference, and this again is according to the people who do this work, how women describe their experience is a little different. But if we were to be clinical for a minute, we talk about the blues as being self-correcting. It lasts a little while, maybe even a couple of weeks, but it goes away on its own, and it is intermittent during those weeks that it's here or during the days that it's here. So someone might get up in the morning and kind of feel ready to go, and an hour later, tearful, crying, feels like a bad mother, and 2 hours later she's dressed and she's out and she's okay, but then when she comes home again, she kind of crashes. It's intermittent, and she is consolable, and she is functioning. Now, for some women who have never had what they would have called depression in their lives, to them this is depression. For women who have had a history of depression, this feels like nothing. Now, that's not so bad, except she might underestimate how badly she's doing because she's kind of felt this before. So again, I always, when I'm talking to women, I want to know, like, how bad do you feel? On a scale of 1 to 10, how badly do you feel? How are you feeling about being a mom? Let's talk about the sleep disturbance for a minute, and that's huge in Lisa's story, and we'll talk about anxiety separately, but it is so typical, of course, it is expected that you will have interrupted sleep as a new parent. Interrupted sleep is very different than not sleeping. And it's really important to differentiate, because if a woman calls and says, oh my God, I'm not sleeping, don't assume to know what that means. We need to say, well, tell me about your sleeping. You know, are you napping during the day? How she answers that is going to tell us something. Are you able to sleep when the baby sleeps? At night when the baby goes to sleep, are you falling asleep? Are you waking because the baby's waking, or are you waking because you can't stay asleep? Once you're done feeding the baby at night, are you falling back asleep, or are you pacing? How many nights has it gone on that you haven't gotten at least a 3-hour chunk at a time? Typically, women will say, oh my gosh, I'm not sleeping, and the provider will say, of course you're not, you have a new baby. But they don't ask. And sleep deprivation is very dangerous. It's what they do when they kidnap you and hold you hostage. They do it to make you crazy, right? They break you down. They take your watch, which, I mean, think about being a new mom, right? They take your watch, they sleep deprive you, they often food deprive you, and they isolate you. That is what happens to a new parent who's home, especially in the winter in Massachusetts, right? You have no sense of time. You're not sleeping very well. You're often not eating very well, especially if you don't have good support. And you often feel very isolated. That would make anybody feel crazy. So sleep interruption is very different from sleep deprivation. And the longer the sleep deprivation goes on, I'm using this word with a very tiny c, the crazier people feel. You lose sense of time, you lose sense of self. Your body gets so dysregulated, you can't put yourself back to sleep. You end up needing medication to kind of re-regulate your body. Obviously, it impairs judgment, and this becomes very dangerous. So it's very important to not brush off when a woman comments about, oh my God, I'm not sleeping. It is so important in this work to not assume to understand what someone is saying. Ask a lot of questions. Be really, really interested in her experience, because her experience is going to be really different than the woman who called you last week, even if they're kind of starting out using the same words. So there's depression and the blues, and then there is anxiety. Now, a lot of times, let me just go back for a minute to depression. People think that postpartum depression happens in the first 6 weeks. You know, women go back to the provider for their 6-week visit. And that 6-week visit has become construed to mean I should be okay by 6 weeks. We have to explain to women that that 6-week visit is a physiological medical visit to make sure your cervix is closed, your uterus has clamped back down to its pre-pregnant size, and we talk about sex, which lots of women don't want at 6 weeks, but that's when we talk about it and send them on their way with their birth control. That 6-week visit has nothing to do with a person's psychological well-being and timing, nor does the 12-week return to work, which has become the other milestone where people think they're supposed to have it all together. That's some arbitrary time that the government decided companies could tolerate before people had to come back to work. But that, too, has nothing to do with women's developmental process. So we need to dispel those myths, because women put a lot of pressure on themselves to be better by 6 weeks or 12 weeks or whatever that leave is for them. We say that perinatal mood disorder or anxiety disorder can happen anytime in the first year. I have women who call and come in and they have toddlers and they'll say, I think I still have postpartum depression. We tend to not use that phrase once we're past the year. But again, there's no official diagnosis, so it kind of depends on clinician. What I will often say to people is, it sounds like you had a postpartum depression that hasn't resolved, but we tend to not call it that, and I sometimes discourage people from calling it that after a year, because then I think they get a lot of invalidation. Oh, you can't possibly have postpartum depression. So at that point we say, look, you have a depression. But really it's any time in the first year. And often in those first weeks people sail through, because that's when they have lots of help. And that's when people are really interested in them and their babies. And the help goes away. Sometimes it doesn't really pop up until they stop breastfeeding or they go back to work, or I get the calls, my mother left yesterday. Sometimes that's a cause for celebration, but often not. So that's the story with the depression and the blues. The anxiety is different. Now, lots of women have anxiety, but they'll say depression because that's the phrase that's used publicly. And that's a jumping off point, and then we can do some education with people about what's really going on. But postpartum anxiety disorders and prenatal anxiety disorders look very different. You're literally anxious. Could be that you're having panic attacks. It could be that you're having some OCD kind of stuff where you're perseverating about fear or health issues. Typically, postpartum, this doesn't happen so much prenatally, but postpartum, women, if they're brave, will say, I'm having scary thoughts. That's a phrase that comes up a lot. And this is something we can talk about in terms of your time on the phone or in group. These are not thoughts of wanting to hurt the baby. These are thoughts about how the baby can get hurt. It's a very different thing. It's like the vulnerability on overdrive. So women will describe being in the kitchen and making dinner, and they'll have a knife in their hand making salad, and they'll literally say, I saw the knife floating over to my baby. They'll never say, I wanted to take that knife and hurt my baby, because they don't. They're not psychotic. They're totally present, but they'll see images of a floating knife, or they'll be walking up the stairs, and they'll say, I could imagine my baby falling over the banister. Or they'll hear water running, and they'll say, I can imagine my baby drowning in the bathtub, even if it's the water in the sink. They'll be crossing the street with a stroller, and they can imagine cars hitting them. And it's perseverative, and they can't stop it. It's Jane Driscoll, in her book, describes it as sort of, when we had records, the needle stuck in the record, and you used to have to literally flick the needle to get it to stop. Now we have CDs, so you stomp on the floor, and sometimes it jumps to the next track. But it's this overdrive thing that women literally cannot stop by themselves. We use medication wonderfully for this. But this is a difficult thing for women to acknowledge, because they don't understand it, and they're afraid that as soon as they open their mouths to say this, that the person hearing it is going to go, oh my God, I got to call DCF. What I tend to do is not wait for women to tell me. I say to them, you know, sometimes when women are having postpartum distress, it will come in the form of anxiety. And one of the things that lots of women describe to me are what they would call scary thoughts. And I say very quickly, not thoughts about wanting to hurt the baby, but thoughts about the ways the baby can get hurt, because you're so vulnerable now. You don't want your baby to be hurt. And it's important for me to know if you're having these, because we treat this. This is very treatable, and often you can't fix this by yourself. And I'll say right away, I'm not going to call DCF about this. I'm not taking your baby. But it would be really helpful if you could tell me if you're having some of this. And either they say no, or there's this huge sigh of relief. And sometimes they'll say, oh my God, I had that the last time, but I didn't dare tell anybody. It's very shameful. And they're afraid that they're going to become Andrea Yates and drown their, and we're going to think they're going to drown their babies. And so I try to differentiate very quickly so they know that I'm not worried about them and their safety, but I do want them to have some relief. And really, this is not something that just runs its course. The depression, if we don't treat it with therapy or medication, for lots of women it will sort of run its course. I don't find that this anxiety OCD thing just wears out. And often, we will see that these are women who had anxiety and OCD issues prior to even pregnancy, if we really start asking the questions. But this can be very, very scary. These women become housebound. They're afraid to go anywhere. They don't want to have company. They make their spouses a little nutty. They check on the baby 1,000 times, or they won't let anyone else hold the baby. Very rarely, 1 to 2 per 1,000 women, we will have a postpartum psychosis. And that's when people lose touch with reality. There's hallucinations, auditory hallucinations, visual hallucinations, severe depression, ups and downs in the mood, mania, confusion, a lot of paranoia. This does go to the emergency room. This is the one where we separate the mom from the baby because we're not sure she can keep the baby safe. We don't worry about needing to quit breastfeeding. We'll deal with her grief and loss later. We get her in the hospital, we get her on medication, and we get her stable. We do the cleanup work afterwards because this is the dangerous stuff. We don't see this often, but it is there. Now, the other piece that we talk about now is bipolar disorder. And often what we see in postpartum women is what we more call bipolar II disorder, which people talk about as sort of a less severe manic depressive kind of thing. And this is a really confusing picture because when women are manic or hypomanic, which is not so manic, they feel good. That's not when they call you, and that's not when they come to therapy. They call you or come to us when they are in the depressed phase. And if we don't ask the right questions, we label them as depressed, we put them on antidepressants. When you put a bipolar person on antidepressants, they become manic. They get worse. But this happens a lot because people don't ask the right questions. So I ask things like, I don't want to assume that I'm only seeing depression, so I'll say, tell me how you've been the last few weeks before coming in here. And sometimes they'll say, I was so great the first few weeks. You know, I lost all my pregnancy weight in the first 2 weeks. And then my whole family came and I had this great dinner and I'm back to running already. And you hear this level of activity that is not typical in the early postpartum time, nor appropriate. And that to me is always like, oh, ding dong, you know what, we need to pay attention to this because now she's not like that. Something's going on here, and I'm going to question bipolar, and I'm going to talk to the medication person to say, check this out, because we want to get her on a mood stabilizer, not an antidepressant, if that's what's really going on. It is a hard conversation to have with women because that label, bipolar disorder, is really scary and sounds very clinical and very awful. And I will often say to women, I'm using this word to help you understand why we're going to probably pick the kind of medication we're picking. You are not crazy, and I'm not telling you you are a manic depressive, but what I am telling you is that you're having a mood disorder that isn't just depression. And we need to treat it appropriately, we need to understand it. And we need to know what to look for if you start racing and going up and down again. But women do not like to have this conversation because there's much more stigma attached to that kind of diagnosis. And often they say, you know, am I going to be bipolar for the rest of my life? You know, sometimes, yeah. I don't always say that, but sometimes it's the beginning of, you know, a roller coaster ride. And sometimes these are people who have had mood disorders prior to pregnancy. But again, when there's no baby in the picture, you know, all of us, when our lives are simpler, we can accommodate and adjust and adapt and look very functional, and it doesn't get in our way. You can be a little bipolar and be really creative and productive, and it looks great out in the world. When the baby is in the picture, it changes your capacities to cope in the ways that you were coping, and that's often why people crash postpartum, because suddenly all their old coping strategies, they're not working, and they're not available to them, and so that's often why they start coming to therapy, because they'll say, you know, well, I can manage.
And I think I'm just, this is all really, really helpful information, and, you know, I feel like I've been a social worker for 20-something years and don't know a lot of this stuff, but one of the things I'm trying to think about as I hear is what the meaning for people on the parental stress line and in the support groups, and we're not ever going to be giving someone a diagnosis. Mm-hmm. We're not ever going to be saying on the stress line, you know, wow, sounds like you might be bipolar. I mean, I'm joking because I know that nobody would actually do that. But it is really helpful for us to know that the variety of symptoms that could indicate perinatal is the word? Perinatal problems. So it's not just if someone talks about things that sound depressed, but also if people talk about things that sound anxious.
Yeah.
It would be a reason to say sometimes when people are feeling very anxious and having panic attacks after having a baby, that can be a sign of postpartum depression or, you know, postpartum depression or anxiety, and folks will see their doctor, or however you want to word it in a way that isn't, you know, go see your doctor. But,
Is it very rare or unheard of almost to have people either in a group or on a phone call tell you of a previous diagnosis they've had?
It's very common for people in the group or on the stress line to tell you, to announce to you that they are bipolar, and that's fine. You know, we don't have to ignore that the person said that. It's just that we're not, you know, we're not clinicians and giving people diagnoses, but very often people will come in and tell us that, or now also very often people will come in and say, my child is bipolar.
Mm-hmm. One of the things you can say if people disclose that is to say, you know, there are all kinds of risk factors for a perinatal mood disorder. And having a risk factor doesn't mean that you will have the mood disorder or that you have one. But if you know, just like for anything, if we know we have risk factors for something, we go and check it out. And I think that that's a reasonable thing to say to someone, you know, you're sharing with me a lot of things that we know to be risk factors. And given that, you know, you might find it helpful to go and speak to somebody who might be able to help you further figure out what's really going on. But at least you're planting the seed that this isn't coming out of nowhere, but in fact, they do have some red flags. And we don't want to ignore those, because if the sooner we intervene, the better we are. I want to say something really quickly that's important, which is that one of the reasons it's so important to really be curious about a woman's experience and her current life situation is that these perinatal mood disorders are not primarily caused by hormones. That's what everybody, you know, would like to think, because if it's hormonal, then we can treat it with pills and then it's all fixed. Hormones are changing in every woman in the same way in pregnancy. But just like not everybody gets nauseous and throws up, not every woman has PMS and every woman's hormones are doing the same thing, not every woman is going to have the same response to the hormonal change, whether it's in pregnancy or postpartum. But there are some women who are particularly sensitive to the hormonal changes. But there are lots of women who are not particularly sensitive to hormonal changes, but in fact have all kinds of other psychosocial risk factors, as we like to say, that are going to contribute to this. Whether it's a previous history of depression or anxiety, a trauma history. I get clients who come in saying, you know, I'm pregnant, my husband just left me. Okay, well that's a social factor. We just both lost our jobs, and now we have no health insurance and we're having a baby. We've just moved to a new community and we don't know anybody. All our parents are deceased and they're not here to help us. We don't have any help. I don't thrive. I have another sick child at home. I am on bed rest in my pregnancy. There are all kinds of factors that can contribute to a woman struggling during pregnancy or after the baby is born. There are some psychosis, we're pretty clear, is hormonally driven. The OCD thing is kind of hormonally, chemically driven. But the general sort of depression, distress is not often only hormonal. And when you sit and really talk to people, there are often red flags all over the place. It is pretty rare that I sit with a client and ask 8,000 questions and come up with no red flags. Once in a while, we find something. We find somebody that has no red flags, but usually there are. So it's really important, again, to be really curious about a woman when she's calling, or the dad is calling, or the mother-in-law, whoever's calling. To be curious, who's around to help. Sometimes people say, well, my mother's coming. Don't assume that's a good thing. Seriously, I say to them, well, is your mother helpful? Is that going to be useful? And sometimes women will say, oh, fabulous. Sometimes whoever it is, mother, mother-in-law, aunt, they'll say, actually, it's going to be more work for me. My mother doesn't drive. My mother can't walk up and down my stairs. My mother's a horrible cook. She's going to want to hold the baby, but even that she can't do long term because she's frail. So when someone says, oh, yeah, my mother's here, oh, tell me, how's that going? Is that helpful? Who's cooking? Who's cleaning? Who's doing laundry? Please.
In my experience, I had a lot of help. I had a lot of family members. One of my largest problems was I had difficulty, because of the illness, bonding with the baby. I didn't feel that maternal love. I didn't look at him and say, oh, he's so beautiful. I just want to hold him all the time. With all the people around me, they were all saying that, and that enraged me. To hear, oh, he's so beautiful, he's so wonderful, he doesn't cry, he's so sweet. All those things that I wanted to feel and say, I didn't feel. And when I heard all of that, it made me really anxious and angry. And that just goes to show what you were saying about asking specific questions. An outsider would say, oh, she's got all the help in the world. Her mother came from Florida. Her sister came from Florida. Indeed, when my sister was leaving, I asked her to take the baby with her. I said, you know what? I don't feel this way. You obviously do. Maybe he'd be better off with you. And I felt that way. Go ahead.
Or sometimes the help comes, and the help thinks that the most helpful thing is to give you a break from the baby and hold the baby the whole time, and so they're not facilitating the connecting. So really, just if the only thing you do on the phone is get really curious, that's going to give you information, and then you get to validate and say, wow, it sounds like, it's kind of a mixed bag. You got this mom, but it's really stressful for you. And so it's not just hormonal. There are all kinds of other things that are going on in people's lives while they're pregnant. People die in your life while you're pregnant, or people are dying while you're giving birth, and people are divorcing, partners are leaving, basements are flooding. Stuff happens, which can contribute. The other thing that can contribute is either medical stuff going on with the mom or with the baby, having a traumatic birth. Sometimes there's a temperament match that isn't quite right between the mom and the baby. I've got this one client now who is this demure, shy, restrained, introverted woman who got this big energy, fabulous baby. But she experiences him as a really, really difficult baby, whereas other people will go, oh my God, he's so engaged and he's great. It's totally overwhelming for her because her energy is really small and quiet. So sometimes when you get a temperament clash, or you get a parent who, if you find a parent who says, oh my God, my baby won't let me put them down, get curious. I'm really curious, what did you imagine it was going to be like to have a baby? Inevitably you get people who either say, I thought I was going to put my baby in the baby bucket and rock it with my foot and get back on the computer and work from home. Those are the people that get the babies who need to be on a body. Or you get the moms who have these great fantasies of, now you can't use slings, but slings and co-sleeping and breastfeeding, and this is the baby who is easily overstimulated and needs to be put down. That kind of stuff is experienced as not only distressing, but sometimes moms will say, the baby doesn't love me. You know how babies grab at faces? I had a mom with a trauma history. She was sure her baby was beating her up. So we have to really explore, what was your fantasy? What did you get? Did you get the gender you wanted? People do have gender preferences. They're ashamed to say it, but they do. And a lot of distress I see is from that kind of stuff. And if we don't ask, and if we don't ask about, well, tell me about your birth. What did you think your birth was going to be like? What really happened? How are you feeling about that? We miss big chunks of stuff. So on the phone, in groups, you're in a good position to give her some airtime and validate her particular experience. You have a question?
I was just going to say the call I got recently. The mom was 21, and she said to me, I wish somebody had sat me down before I had this baby to tell me what my responsibilities were going to be. I didn't realize I was going to have to do all this stuff. And she is one that does put on a happy face and doesn't tell her husband or her in-laws who she's living with about what she's experiencing. And she misses, when am I going to be able to go out with my friends? When am I going to go out to party? I can't do that anymore. I really miss that.
When there's a big disconnect between what people thought it was going to be like and what it's really like, that's often where everything starts to bubble up.
And that's actually a risk factor. She's young, 21. Was it a planned pregnancy?
No.
Yeah. That's another huge risk factor too. It's interesting. We have a call that we were taping parental stress line calls for a while to use for training and evaluation purposes. And we have one of those training calls where one of our volunteers is talking to a woman who's a registered nurse who was having had real problems with infertility, difficulty conceiving. After years of trying, had twins, and was so depressed and unhappy. But the fact that she was just putting herself down because these babies were so wanted. She tried so hard to have a baby, but now she has these two babies there, and they're really difficult. And she never thought about what it was going to like to have a baby. She thought about having a baby. And I think that I think it's really powerful when someone doesn't expect to be pregnant and then becomes a mother. But even people who are longing for pregnancy often don't have a sense of what the reality is like. I think also because we no longer live in communities where people live intergenerationally, so a lot of people don't have any contact with infants until they first have a baby. And
there's also a feeling of I'm not entitled to complain because I worked so hard to get these babies, and I spent $80,000 getting these babies, and I went to Timbuktu to get this baby, and who am I to complain? So there's a lot of shame and secrecy and isolation in that way as well. Did I answer your question about self-diagnosis versus
That was my
versus
that's
clinical diagnosis? Okay.
Randy, did you have a question? I don't want to put you on the spot, but you had a question that had something to do with foster care and postpartum depression?
Well, I think it's been covered a little bit. I'm more thinking about group situations where we know parents better than on the phone, and how I guess how the system generally kind of plays out when a woman who is in one of these, I'll just use postpartum depression, situations, and DCF does get involved in their lives. And I guess what suggestions you'd have for how we support them in group as they're going through that, and the system is dealing with them in its own way, which we obviously can't control.
Right. Great question. So are you talking about situations where the babies have been taken away, or?
Right,
yeah. First of all, I think in the ideal, we get some better training for DCF workers so that people understand why they might be seeing what they're seeing in some of these families. Obviously, children need to be removed if they are in danger, but how we work with those families afterwards to help them become good parents, I think is informed by how we understand what's really going on, and I think we need to appreciate what postpartum is for people, and not just assume that these people have no parenting capacities. You know, obviously it always depends on the DCF worker and how savvy or consistent the worker is. But I think that certainly within your groups, you know, if you can bring this whole perinatal issue into the room, anybody who's had children has gone through the postpartum time. And while not everybody had their kids removed, everybody had probably some distress, if only to just adjust to new parenthood. And so if there's some way to, you know, sort of normalize the distress, and that, you know, the fact is some of us have stronger coping skills than others, and some of us have traumas that will make having a new baby more triggering, and some of us have other kinds of issues in our lives that compromise our capacity to do the right thing at certain times. I think in some ways normalizing it so that people have permission to talk and not just feel like, oh my God, there's something horribly wrong with me and they took my baby. You know, it's a tricky thing because you all don't have any control over what DCF decides to do or how appropriate they are in their interventions. My experience with DCF is not great, with pretty poor follow-through. So I think, you know, in whatever ways you can also hook up these families to other kinds of appropriate postpartum support services or infant mental health services, so that when they are with their babies, they're getting the proper interventions so that they, one, can heal, and two, learn proper parenting, and medication providers in their area so they can get to people who are properly trained to do this work. In our state now, there's the North Shore Postpartum Task Force. There's the Cape and Islands Maternal Depression Task Force. They have a web thing. I don't know if Lisa put that. Yes, she did. We are working on a South Shore Postpartum Support Network, which will have a website live hopefully in a couple of months. So those are some regional task forces that are putting together their regional list of providers. And then PSI is putting together, is sort of taking all of those and having all of that within their reach. So if someone calls the PSI warm line, they will get it. So what we're trying to do is decrease the gaps and the fragmentation. And I think that just supplying that information and making these people in your groups feel like, you know, there is help. The thing I love about this work is that this is treatable. And I hate to use the word treat because then we're saying there's an illness or disorder, but it's the lingo we use. This is fixable. And it doesn't have to take a really, really long time if we get families hooked up in a timely fashion. I want to have Lisa sort of be the caller for a minute. And you all be the answerers, whatever you caller, callee. No, you're not a callee. You're the caller and the responder. Just to kind of get, she's going to sort of call and say something about her struggle, and I thought it would be helpful to just have people brainstorm different responses, different things you might ask, places where you might get stuck on the phone and not know whether you're kind of going into territory you shouldn't be going into, or just to kind of see what comes up and what are the things that you most need to tweak in your work, in your particular roles, when somebody prenatally or postpartum calls. So be the caller.
Okay.
You say, ring, ring.
Ring, ring. How do you answer the phone? Parental stress hotline?
Hello, parental stress line.
Hello. My name is Lisa, and I have a baby. He's a month old, and I've been calling all over. I don't know who to call next. I saw your number, and I thought I'd call you, hoping to get somebody live.
Well, you have reached somebody live, and really, really happy that you called. And it sounds like you've been calling and calling to get help. That must be really frustrating.
Yes, I've been leaving a lot of messages, and I just am not getting the right kind of information that I need. The reason I'm calling is because I had a baby about a month ago, and I'm feeling very overwhelmed, and I'm feeling very sad, and I find myself crying a lot, and I can't sleep, and I can't eat, and I want to know if I'm ever going to get better.
jump right in.
So you will get better, and it might still take a little while. Why don't you tell me a little bit more about some of the things that you've been feeling? And if you could tell me whether there are things that you felt before at any other time in your life.
Well, this is my first baby, and I feel very isolated, and I feel very afraid to leave the house, and I feel like the day is so long, and I feel like it's never going to end, and I feel like he needs so much from me, and I feel like I don't know what to do with him. So I've never felt this way before because it is my first baby.
Well, there's a lot that we can talk about, but I want to start by saying how brave I think you are for making this call. It is not easy for a mother to say, you know, life around having a little baby isn't working for me. The day feels long. That is a very brave thing for a mother to say, and it is something that mothers feel. Mm-hmm. And there are other mothers that feel that way, and there is support around for this. But let's talk a little bit more about your situation specifically.
Well, everybody says that he's sweet, but I just don't feel that way about him. I feel like he's an alien. I feel like he's not what I expected to be like. I thought this was going to be all bliss, and I'd want to hold him all the time and sing to him. And I just don't know who this person is. I don't know how to relate to him. I feel like, I guess I'm having a hard time bonding with him. And I just can't relax. I wish I could just relax. But my whole environment feels so different. My house doesn't feel like my house. And I feel like I can't really talk to anybody about this because all of my friends who've had babies recently tell me that they're happy and it's such a wonderful thing, and I just keep hoping that tomorrow I'm going to feel better. But it's been a month already and I'm not feeling any better. I just feel very sad. Maybe I shouldn't have had this baby. What do you think I should do?
Jump in.
Just give it a stab. Doesn't matter if it's all in your face. Just try.
Go by your gut.
Because she's going to be on the other end of your phone line or in your group.
Are you able to talk to your husband?
You know, I just don't think he understands. He loves this baby so much, and I listen to him read to the baby and sing to the baby, and I think, oh gosh, I wish I felt this way. He sounds so happy to have this baby. I don't know, if I say something to him, he's just gonna tell me that it'll go away, or I'll feel better. I really don't feel like I can talk to him. I don't think he understands. We agreed that he was going to go to work and I was going to stay home with the baby. And I'm lucky I don't have to work. I don't have to worry about going back to work in 12 weeks. And I feel really guilty about feeling this way. I don't want to feel this way. Do you think I'm ever going to feel like I'm in love with this baby?
Well, it sounds like you're having so many different feelings. You're feeling sad, you're feeling guilt, you're feeling like you can't really talk about this with your partner, that he wouldn't understand, so you feel misunderstood. It sounds like you're having so many very, very valid feelings and normal feelings. People feel this way after having a baby. It's a myth that everybody feels great all the time. And if you have friends that are telling you that everything is blissful all the time with a baby, there's something they're not telling you.
That's what I was thinking. I keep questioning them, but they won't bite.
Yeah, and you know, what's important is how you're feeling. You know, not how they're feeling. What's really important is how you're feeling, and what you're feeling is valid. And you know, you're not just talking about feelings, you're also talking about behaviors. You're saying you're having trouble sleeping, you're not eating. So in addition to having all these feelings, you're having a really hard time taking care of yourself, and you're having a hard time taking care of the baby. Now these are things these are behaviors and feelings that come up for women after they have babies, and there's help. It's not something that lasts forever. It's not something that, you know, just for you to know that there's hope. And there's people that we can connect you with. Sometimes people find it helpful to talk to their doctor. Sometimes people find it helpful to go to a website. There's a number of websites I can give you. There's a warm line phone number I can give you. Now, warm line means that when you call that number, you won't necessarily get a person in that moment, but someone will call you back. And somebody I know told me, somebody I really trust, told me that you will get a call back in a reasonable amount of time.
Let me just say for a minute, it's so important what you just said about somebody you know and trust. One of the things we know is that we can make referrals till we're blue in the face, but if we don't do it in a way that's sanctioning, she won't call. So making it sound like you know the person or you know the organization, making it okay to make that next call. It's already taken a lot of energy for her to make the call to you. It's like the last thing she wants to do is make another call. So do what you can to really sanction the next step that you're trying to encourage her to take. And even maybe, I don't know if you guys do this, but you know, please call us back and let us know if you made contact or something like that. Because so often doctors particularly, they'll go, here, take this card, I know that therapist, call her, bye. See you at your annual exam next year. Well, that's not going to do it.
And if Lisa was telling the same story and she was in a group instead of on the stress line, what I would do is engage the other people in the group to reflect back to her how valid her feelings are and how difficult it is for parents when they have a baby. And the group can be so powerful when another mother says to you, I was going crazy. I thought I was going to lose my mom.
Do any of you get calls from the dads who are concerned about the women?
No, we get calls from them.
Because it's really, you know, we're talking here about the women because they're the ones who carry the babies and birth the babies and do have hormonal ups and downs. But there's stuff that's just starting to be written about dads and postpartum depression. There are a couple websites, like one's called like Postpartum Dads or something. Dads don't have the hormonal up and down. They don't have stitches. They might be trying to lose weight. They're not bleeding. But they're also having interrupted sleep. They're also sometimes not eating very well at all. Sometimes it's their mother who's there driving them crazy, or their mother-in-law who they don't get along with, or the partner doesn't get a lot of time off from work and he's got to go back to work really quickly, which can be both relieving but also hard because you're straddling this new world and your old world at the same time. If you're going to work, you know you're leaving your partner at home who's not doing very well. So, and dads don't understand very much about this. And so it's really important to do a little bit of educating on the phone if the dad calls, both for about his own depression, but also what might be going on with his partner. And to really not dismiss, and if the dad calls just about the partner, to ask about the dad himself as well, because they get lost in the shuffle. Everyone looks at the baby, and then how's mommy doing? And, you know, where's dad? You know, isn't he great? He's cooking dinner, and he's miserable, and he's worried, and he's disappointed. I get a lot of dads who, they are so disappointed because their partners aren't having a miserable experience. Wasn't how it was supposed to be. We were supposed to be madly in love after this baby came. This was going to be like another honeymoon. Not. So I have dads who get angry at the women, who feel ashamed that their wives aren't doing well, who are really hard on their wives. Well, I don't understand, how hard could this be? You're just home all day. How hard could this be? I didn't ask you to make dinner. What are you doing all day? Why do you need to go to a support group every single day? So we need to really help the dads with their own depressions and their own distress and changes, and also help them understand what's going on with mom. This is a family issue, and when you've got other family helping, it's the grandparents' issue, it's the siblings' issue. This affects the whole family. The ripples just go out. And so it's important to not forget about the other players.
So I have a question about Lisa's situation. I wouldn't assume by any means, if I were just, you know, on a phone call, that the person had previous experience of depression or something like that. But it is something that I would try to get to. So in a case like, and what I would want to know in part is whether whoever was the person that, was that person was seeing, whoever was their therapist, is that still someone who they can access since they have the background? Is that someone they can talk about medication with, whatever, right? And at least we didn't get we know that eventually you got some connection with a previous therapist, but that obviously was not something that you ended up using a lot. But it would be something that, as someone trying to help would try to get at. But I didn't get to that. She said that she had never experienced that before. In which I guess I would assume that I then just leave it. I don't try to probe that any further, right? I don't try to see whether indeed that...
I would say with us in a group or on the phone, it isn't our job to really probe that further. The only thing that's really important is sticking with what she's feeling, empathizing with what she's feeling, validating what she's feeling, and giving her some idea of her strengths, giving her some positive things to feel about yourself. At the bottom, you always have that the person got themselves to group, which I know is no small thing, or the person got themselves to pick up the phone. That's huge, that we can give everybody really strong positive feedback for having done that. But then there's other things in the course of a conversation, but really what we know we can do and be successful and helpful is to identify those feelings, empathize, and it is important at the end of a phone call when you've really identified that a person has these risk factors, it is really important that they come away with some resources. But just having made the phone call, just having someone that talks to them that says you're not a bad mother and that this is one of the normal reactions to having a baby, like the person will be in a little bit of a better place.
Let me say just a little snippet, not because you are going to do the treating, but I think it's important for you to know the different ways that this gets fixed so that you can impart some sort of optimism to the people on the phone, because it can feel incredibly bleak. It can feel hopeless. People will say, if this is what mothering is, forget it. I'm not doing it. Take the baby. I had a client tell me that the next morning when I went to get my paper at the front door, I was going to find her baby. And I said, well, but I know where you live because I have your address, so I'll be bringing your lovely baby back. But people get so anxious that this is what all of parenting will be because you can't see beyond the moment that you're in. Ideally, it's a combination of therapy, medication, support groups, and it's any combination of that stuff for people. We tend to not want to do only medication because only medication sends the message that this is just a chemical thing, and if we change your chemistry, you'll get fixed, and that will be that. And what we know is that, one, there's a whole context that needs to be addressed, and as I say to clients, the medication's going to change your chemistry a little bit, and that's going to help and take the edge off so you can make good use of other supports. The medication's not going to change the quality of your marriage. It's not going to change the temperament of your baby. It's not going to change your job situation, all these other things. So therapy or some kind of supportive context, a group, for some people it's a chat room online because they can't get out of the house. But some sort of other context besides medication is important because there are all those psychosocial issues that need to get addressed. And at the very least, there's some healing work that has to be done around sense of self and shame and reconnecting with the baby properly that is pretty hard to do all by yourself. And so therapy for sure of some sort, medication for some people, not everybody. I have clients who really want to be on meds. I don't really think that's the thing for them. Sometimes I can discourage them, but sometimes we just do a low dose and they feel like that's helping and we do all this other therapy work. Some people really need to be on medication and they will do it. Some people really need to be on medication and for all kinds of reasons they will not do it. We go, as a therapist, I go as far as I can. If I really feel like their symptoms are getting in the way of using the therapy, I'll say, look, I cannot make you take medication, but I strongly suggest it, and I'm not sure how much more helpful I can be if we don't kind of tweak the chemistry here because it's really getting in your way of functioning. I think new mom support groups are great, but they are very hard for people who are having postpartum distress because the happy mommies are at the regular new moms group. So there are some postpartum depression groups, not a lot, but there are some. I have a lot of people who use online boards and chat rooms. You can do it in your nightgown. You can do it at 2 in the morning when you're up and your baby won't sleep. Some people are very anxious about going to groups. It stirs up all kinds of junior high stuff and social stuff and whatever our stuff is about groups. So often, at least online, though they're not all moderated groups, it is an opportunity to hear other people's stories, write in. You can lurk or you can actually write in and participate. But a lot of moms find the online stuff a real lifeline. Dads are more likely to do online stuff than to go to a group. They often won't even do the online stuff, but there are a couple of postpartum dad online things now that are pretty good, and it's just the dads writing in, which is really wonderful. Can I just say something?
Yeah.
The bottom here is a postpartum blog, postpartum progress blog. That's very useful for in terms of support, and there's also a section there called Warrior Moms. A lot of women who are going through perinatal mood disorders want to know what it looks like on the other side. They want to have access to a survivor. They want to know. That's why I go around and I'm very open about my story, because I know I was looking for that person who I wanted to get to be. And on that website, there's a whole section called Warrior Moms. Women will have their stories written down. It's very easy to find. They have their stories, what they experienced. Your callers may be able to identify with their stories, their symptoms, and know, wow, look how happy they are now. I'm going to get there. I just wanted to point that out too. The other thing, and partly this is dependent on finances, but for some people the whole therapeutic nature of some groups is just way too daunting. So exercise classes, hanging out in the park during good weather when there's other moms around. I tell people, just please get out of your house. I don't care if you sit on your front stoop and wave at the school bus going by. Put your clothes on, get out of the house. Get on the bus, go to the library, go to Dunkin' Donuts, go to the mall, go somewhere. You have got to see other human beings today. It is boring to stay home with a baby, cute as they might be. It is boring, it is janitorial, it is monotonous, and it looks like it never ends. So get out.
But I had a mother who, and there was also another young mother who was living, I think it's the same one, living with her husband and her in-laws, and they were Chinese, and they had to stay in the house for the first month. And it had been 3 weeks, and she was going crazy.
And that's a tricky one, because, you know, in the ideal, that cultural idea of staying in could be wonderful if you've got the right support, but, you know, when you're doing that outside of the cultural context, in a culture where nobody's staying home for 4 weeks, that's a hard one.
And this is the woman that wasn't telling her husband or in-laws how she was feeling.
Yeah, and I mean, also, if they're Asian,
Yeah.
Typically the Asian culture doesn't do therapy. They don't talk about what's going on. I mean, just the fact that she's calling is humongous if she's Asian.
And often the daughter-in-law has to do the cooking for the in-laws. I mean, that's expected. I don't know whether that was going on.
Yeah, it's, I mean, you always have, again, context. That's a hard one. But maybe she could get online.
Right.
She's home. If there's a computer, maybe she could get online.
Well, that's what I Googled while I was talking.
If they have computers, or else go to the library and get online, unless your library's closing.
Can I just make a suggestion about too much information
To give, you know, a woman very overwhelmed. Sometimes only one website or one phone number is going to be the best thing, because she's not hearing everything. She's just all over the place. If you, depending on what she has to say, I don't want to tell you what's the very best for every woman, but I think a really good starting place would be the Postpartum Support International. If you're going to give one website, I would start with Postpartum Support, because that will lead her to anything local that she needs to get to, and will link her to a lot of these others. Are there questions? Are there questions that I have not addressed? I mean, it's almost 8:30, but I'm happy to stay a little bit longer, and I want to make sure you're walking away with what you need.
I have two questions. One was, is there a point, I mean, I understand that this isn't something I would lead to right away in a phone call, let's say, but do some mothers bond at a later stage, was what I was thinking, that there's some behavior on the baby's part that developmentally will be something she connects to more than, you know, let's say in the first month or two.
Mm-hmm.
What the baby, maybe she needs more from the baby.
Mm-hmm.
Or
Great question.
I love that
Yeah.
question, and 3 years ago I was Googling bonding, and I didn't find anything, and I'm looking at all my books, and I didn't find anything. I said, I cannot be the first mother who doesn't feel bonded to her baby. And you know what? Can I answer this in a very lay way?
Yeah.
For some women, infancy sucks. Okay? They just don't like it. You know?
Yeah.
Baby doesn't give anything back to me, but eventually that baby will start doing something, which will bond them. And I really think it's something that the mother has to work on, and she has to be encouraged that it's going to happen. I don't know when it's going to happen, but it's going to happen, and she can work on specific ways to facilitate it happening. For me, it was singing and talking to my baby, and being well enough to do that in a way, you know, not doing it all the time, but just in those glimpses of the day where I felt okay about myself, doing it then. And then whatever I got back from him was a building block to the next thing. I didn't feel better until Thanksgiving, which for me was 11 months. I didn't start feeling like this is my baby until he was a year old. I was a toddler person.
Yeah, some
I'm
people
not a
really
baby
are.
person.
I had one
Right.
client who could not stand her infant. And when I asked her, you know, well, tell me about yourself, because, you know, you told me you and your husband have always wanted kids, and she said, keyword, kids. I wanted an upright human who would hold my hand and walk down the street. She said, I never had a vision of a baby. And she was very bright, and she said, you know, I don't know where my brain was, but... And one of the things I often say to people is, again, it's another myth that there's instant bonding, and it's also a myth that you've got to have the instant bonding or it's all doom and gloom. And I'll say, you know, it's a little like dating. There's a courtship that's going to happen. Some people do fall head over heels in love after that first date, but sometimes you got to live with the person for a while before you really know them and know their quirks and know their cutenesses, and you will fall in love over time. And at the beginning, at the very least, there is, unless someone's really disconnected, there's at least a primal urge to caretake in a very basic way to make sure the baby's safe, even if it's giving the baby to your sister. There's some primal thing that is about, I have to take care of this thing. And if that's what you do at the beginning, that's okay, you know? And there are lots of ways to mother, and sometimes the best way that you mother, particularly when you're struggling postpartum, is that you make sure there's some other loving person there for your baby. And as you are ready, you will date and enter the sphere of this baby. And it is painful for people, and then there is some grief work we have to do when they're feeling better, and then they look back and say, oh my gosh, I missed the first 11 months, and we do grief work. I mean, that's just what we do. But most of the time, these women will be very resourceful in finding someone else to love the baby. Now, there are times when we have failure to thrive babies because the family is bereft and doesn't find that person. And we've got to do a lot of repair work with the baby as well afterwards, which is why the whole field of infant mental health has really taken off, and it's very exciting. But even for women who aren't having depression, they'll say, I don't really like this baby thing. And I just talk about courtship, and I will say and it is really true, I have yet to have a client who did not at some point cross that threshold. It might have taken a year till that child was upright, but it did happen. And in the meantime, they do the basics. They do provide stimulation and food and warmth, and they're just not loving it. And I also give permission that you don't have to like every phase of child rearing. In 20 years, you are going to look back and say, I hated this part, I loved this, this was okay, this was tolerable, I loved this part. But when you start out, you can't know, really, except from any babysitting experience you've had, I suppose, what you're really going to love about parenting and what you aren't. And you don't have to love it all. You have to do a reasonable enough job and keep the kids safe. But you don't have to love all of it. And how could you, really? And there's some pretty awful parts. But your other question?
Well, it's she was a mother of two, and she had a miscarriage.
Right.
And she sounded classically depressed. Not that I really know what that is, but absolutely no color to her voice at all.
I think, when somebody calls with perinatal loss, I mean, you do the same things, right? You validate.
I was afraid to, yeah.
You validate. You say it's so great that you've called. Eventually, you make sure she gets off that phone with some resources.
And that was the hard part, because I was just afraid that the ones we have in our referral manual list would say something to her about the baby, that it would immediately assume she had had a baby. And she probably would have been fine with that, but
well, what you can say is, and again, because you guys aren't therapists, you get to say, it sounds, however you all say it, it sounds like it might be really helpful for you to talk with someone who has some experience. I want to give you a connection to a warm line. And you can say, they're going to answer the phone as postpartum something or other. Don't worry about that part. When the person calls you back, tell them that you're post-miscarriage, because the people who do a lot of postpartum work will also do pregnancy loss work.
Oh, okay. All right.
And, I mean, I can give you some separate things, but we're all the same people. I mean, that's the work we do.
Okay.
I mean, I can give you some specific loss resources, but I think that as long as you say, here's a number you can call, and don't be put off by how they're going to answer the phone. Just tell them why you're calling, and they will get you to the right person. But let me just say, around pregnancy loss, birth loss, for people who are going to be sensitive to hormonal changes, that part's going to happen because their hormones are changing after the loss. And if they, grief is grief is grief, and it's grief related to childbearing, and symptom-wise, in a lot of ways it looks the same.
Okay.
Well, thank you so much. This
You're
has been
welcome.
such a rich evening. I'm so grateful that the two of you came, and the way you worked together was really lovely, and sort of having your phone call or visit to the group was really, really helpful, and just having, just more facts under our belt so that we know what we're looking for and what the risk factors are. And
please pass this resource information on to anybody you know in any context who works with new families, pregnant women, postpartum families. We can't get this information out fast enough. Every pediatrician should have these lists. Every pediatrician, obstetrician, primary care physician, midwife, lactation consultant. There is just no excuse for not having this stuff.
And you
so
know what?
Please
You
pass it
guys
on.
should tell people about us, because when they call at 2 o'clock in the morning, there will be somebody at the other end. It won't be an expert, and that person will give them a referral to your warm line. But if they absolutely need to talk to someone at 2 in the morning and the baby's crying in front of them and they feel like they can't touch it.
Do you get those phone calls? 2 o'clock in the morning?
Oh, absolutely.
People are at their wits' end.
Yeah, we do.
It's a very long time. I am always available for consults or phone calls. I have a website, a phone number, I can brochures I can pass around.
Great.
Whether you refer people to me or not doesn't matter, but I like to make myself available to the people connecting with these women, because the better armed you all are with information, the more helpful you can be to people in the community.
I just want to say something very quickly. Have you all heard that there's a postpartum depression bill at the State House? Oh, okay. So this is the other thing people don't know about. There's a bill. It's called the Postpartum Depression Bill. It's sponsored by Representative Ellen Story, who's from Amherst. And the bill will mandate, political thing, so you have to think about how you feel about this. It will mandate screening in the obstetric and pediatric setting.
Now, it won't mandate treatment, because that makes people crazy. We will mandate screening.
Screening. So all pregnant and postpartum women will be screened routinely at their obstetric visits and their pediatric visits. It's unsure how many times, at what intervals, but just like pregnant women go in and they pee in the cup, and that's their screen for their protein levels, they'll sit down twice during pregnancy and fill out a self-screen just to determine the risk factors, and then also in the pediatric setting. So the bill just was heard by a legislative committee to determine whether it's going to move along, but if you see anything about it in the papers, then
I think BUR, NPR had something on it a week or so ago. Yeah, I missed it, but you can get it on their archive. And it's very important because, you know, once you're discharged from your 6-week OB visit, as a family, your pediatrician is the most. And they are not well educated about this stuff. They're actually quite misinformed. And they're very afraid of mental health stuff. And so we're trying to make this screening easy for them to do, not scary, and then make sure they have the resources so they can make the referrals. We are not asking them to diagnose. We're not asking them to treat. But we're saying to them, in order for your child's patients to be as healthy as they can be, their parents need to be doing well. And if you're not catching a distressed parent, and often you don't because they come in looking okay, and you have a 7-minute visit, but if you're not catching that, then what you're getting as a pediatrician is, you know, weekly phone calls about kids' behavior problems, kids' eating problems, kids' sleeping problems, and that's the parent saying, I'm not doing very well at this, I need some help, and they're not addressing
Well, it's the same way in which people are automatically screened for abuse. It's the same preventative. If you ask everybody, they don't make any assumptions.
Thank you all for the work that you're doing. I think, you know, the more entry points we have for people to get help and assistance, the better. You know, different things are going to appeal to different people, and calling someone anonymously at 2 in the morning is easier for a lot of people than going to a group and self-identifying. So I'm so glad that you're all here to do this work.
Thank you.
Lovely
Thank you
evening.
so much. Thanks to the people who called in. I'm signing off now.
Yes.
Because I do